Hello, everyone. Today we are doing another part in our series of interviews with MPS members who are doing work in the community. And remember, everyone, the goal with this video recording is to try to, number one, highlight work that MPS is doing, but also make it relatable by bringing in MPS members who are involved with that kind of work. And for this talk in general, the reason that we have Dr. Taylor Scott with us here today is to talk a little bit about the recent issues regarding revisions of the COMAR regulations, the Code of Maryland regulations. I got that right. That specify the rules regarding care that's provided in the public behavioral health system. So recently, there's been a bit of a stir because these regulations were revised, in particular for outpatient mental health clinic, which are a lot of the clinics that serve the Medicaid and Medicare population in Maryland. These regulations were up for revision, and the revisions came out to people for feedback, came out to community partners, and there was a bit of a stir because there was a change in the regulations that had not been there before that stated that medical directors could only be physicians. And for a long time in Maryland, for many years, nurse practitioners have been allowed to be the medical directors in community clinics. Maryland Psychiatric Society has long opposed that stance and advocated against it when the legislation was changing and tried to even have the legislation revised. And years later, but with these proposed revised regulations, this again opened the door for this discussion about nurse practitioners being medical directors, or more appropriately, the regulation that says a medical director can only be a physician. So that was a very long intro, Dr. Scott. Forgive me, but I wanted to set
the stage. One now.
I wanted to set the stage as to why we're having this discussion today. But more importantly, I wanted to have the opportunity to introduce Dr. Taylor Scott, who is the Chief Medical Officer at Catholic Charities of Baltimore, also one of our MPS Advisory Council members, and highlight her and the work that she's doing, both for Catholic Charities in the community, but also within MPS. So thank you for doing this brief interview today, Dr. Scott. It's good to have you.
Yes. Thanks so much. Thanks for having me.
Cool. So I wanted to start just hear from you a little bit. Just tell me what you think it means in general to be a medical director, and you can use technical regulation talk, or you can use your own verbiage, as whichever you choose.
Oh, given the option, I'm going to choose my own verbiage, of course. So I think of being medical director as you are sort of at the head and responsible party and overseer of all clinical care within that location. In this case, we're talking about outpatient clinics, the clinical setting. So you're responsible for the care that's being provided, whether that's by your own care, the care of other physicians, nurse practitioners working with you, or even therapists, other members of the treatment team. But you are the overseer of that all.
That's right. So it all rolls up to you ultimately.
Yes.
Gotcha. Now, we should have stated Catholic Charities has several outpatient mental health clinics across the state.
Yes.
Remind me how many?
8.
8. Okay. So therefore, you're ultimately responsible for overseeing all that clinical care, correct, directly or indirectly.
Correct.
Gotcha. So tell me a little bit about your background, or tell our audience about your background and how that presumably prepared you to have that level of responsibility and that knowledge base to be able to execute that role.
So it's been a long road. I obviously, went to college, did that experience, and then did 4 years of medical school, and then went into residency in psychiatry, and also did 3 years there, and then did 2 years of specialized training as a child and adolescent psychiatrist. So there is the medical piece as well. And immediately out of medical school, I started working for Catholic Charities and have been in multiple treatment settings and in a physician role in the outpatient world, in the crisis center, have served as their director of psychiatry education. I then went on to be the medical director of the outpatient services, and now in the role of the chief medical officer, which is kind of the senior medical director in that capacity. And, through all of that, there are different pieces that came together that equipped me to be able to serve in what feels like a very important, very heavy, but wonderful role all at the same time. I mean, the medical training is really the foundation of what allows me to do what I'm able to do in a confident way. So there is many years of medical training where you're training in different settings and different specialties to kind of really be able to take a really holistic view of a patient and like really view a clinical situation from many different angles and be able to have kind of a nuanced sort of perspective when it comes to what might be contributing to a person's clinical presentation. And then certainly there's the clinical experience that came after that. And the working for Catholic Charities out in the community, and then the administrative obviously is an important part of it as well that was provided by moving through the ranks and the different leadership roles.
Yeah. Yeah. Not only do you have to do the work, but you have to directly supervise staff that's doing the
Right.
work. So
Yes.
having a firm knowledge base is presumably key to ensure that you are guiding
Yes.
people appropriately.
Yeah.
Yeah. Yeah. I found over the years that that medical director role in the outpatient mental health clinics setting, my outpatient mental health center setting, one of the key parts of my background that helped me do that effectively was really understanding all those different systems, right? Like helping clinicians understand how to move patients through the system, and having trained and worked in different settings certainly prepared me, I think, better to be capable of not only providing that care, but also guiding others about how to provide that care. Just curious your thoughts about that. I know you've been through training and through your experience, you've worked in a number of settings. How important is that in providing this medical director?
I think pretty critical, especially when it comes to sort of making sure that there is an appropriate sort of allocation of resources and as far as the systems in the state of Maryland. So what we never want to see is a patient not doing well and sort of at a stalemate at a given level of care,
Yeah,
where they're just not getting better and we're not seeing progress and still they're just kind of waiting. And so the way that we sort of prevent that from happening, hopefully, is to make sure that the clinical setting fits the need and the ability to see when somebody is no longer appropriate for a given level of care. It depends on your experience of having seen and experienced
that
and
level of
walked the
care.
walk in those different
Right.
levels of care. So,
Right.
how do you tell if somebody needs crisis services or if somebody needs to actually be hospitalized or if a kid might benefit from being in a residential treatment setting? You can't really have a true understanding of whether that's a good fit, whether it's clinically appropriate, unless you've seen the benefits of that setting and the criteria for which, that sort of setting is appropriate.
Yeah, absolutely, absolutely. This seems obvious, so but maybe just explain a little bit more, like how your experience and training helps you to be effective in navigating all those levels or navigating all those nuances of mental health care, including like therapy too. Like since ultimately you're responsible for all the services that are delivered in a clinic, I'm just curious about that aspect and even guiding therapy.
Yeah, we at Catholic Charities, we do a really wonderful job of having kind of a very cohesive treatment team. And part of that role as a physician, as medical director, is being in charge of those treatment teams on a single level for my own patients, but also the treatment teams that are happening for the providers that work with me. And so a lot of times we do find ourselves really contributing in a very significant way to what our therapists are doing in their sessions. What are the treatment modalities that they are recommending, that they are kind of performing, but also again, sort of understanding when another setting might be appropriate. And so, my experience at the crisis service, for example, is a great space in which I saw firsthand, the benefit of that level of care, but also how sort of the acuity can be addressed in a productive way. So without that experience, it would be really hard to be able to lead people in that role. Like, hey, this is what happens at this level of care. This is what this patient needs. I can't speak on that if I haven't seen it, but fortunately, because of my experience, I've been there. I've seen it.
Right, right. or just having knowledge. I would add on having knowledge of adjunctive services, like maybe to avoid higher levels of care, right? How do you add on
Certainly.
PRP services, psychiatric rehabilitation
Yeah.
programs, or how do you alter the the therapy modality in order to more effectively treat the patient's needs? Like having knowledge of all those things
Right.
is quite critical. I'm going to put you on the spot a little bit and maybe give me an example of a complicated case where it was critical for you to have understanding of, again, all those aspects of mental health care, delivery, levels of care, types of care, in order to effectively treat a patient, and how you went about, I guess, executing that or guiding those who report to you about how to execute appropriately.
Sure. So, I was supervising a physician with a case of a child who was in DSS custody, was having, some ongoing behavioral issues, really, really unsafe behaviors, and unable to be safely maintained with the biological family. So, thus, ended up in DSS services for a whole bunch of different reasons. But the issue became not only the symptoms, but also the child went to the emergency room and was actually actively seeking to be hospitalized. And that's where they were headed. They wanted to be hospitalized. They wanted to be in a residential treatment facility, really as a means of not being with the family system. And so, without any further intervention, I truly believe that that's where that train would have gone. That would have left the station, and that's where that story would have ended. That eventually that child would have gotten their way, maybe with some subsequent hospitalizations. There, so the what I really encourage and what I really had to step in with the treatment team was to help them understand. Listen, let's understand. Let's back up first. Let's get an understanding of what's going on with the family system. What services does the family have in place? How are we supporting them? Have we really exhausted all that we have? So does that child have PRP? Have we really dug into the family dynamics with the dad? And, why is the child trying to get away from that family system? What supports does the family have? Do the parents have? Really kind of exploring those pieces as well. And then also giving some advice for, we can stop this repetitive sort of inpatient hospitalization. I would argue inappropriate use of resources. That's really not what they need. Let's talk about, would they do better with the day hospital? Do we need to consider respite services? Really kind of pulling in these other ideas. Do we have a mentor that we could perhaps put in place? And so we were able to get some of those pieces in place. And right now the kid is actually stabilized at their parents' home, which before they were in and out of hospital back to back to back. And so while still tenuous, I would say we have at least stopped that really kind of that, again, that train that had left the station. We were able to kind of stop that pattern of hospitalizations as a mean of like being in constant distress to avoid a family situation that really hadn't been addressed on a family level with the services that are available in the community.
Right. Well, that's great. No, I think that's a perfect example of how adequate training, adequate experience, a thorough knowledge base helps really impact care, because you think about the path that that child might have taken, and heading into RTC and institutionalization potentially as part of that, and certainly the cost that comes along with all of those higher levels of care. So you, in many ways, have not only protected that youth from those poor outcomes. I mean, not that they necessarily would have poor outcomes as going to RTC, but potentially, but also saved healthcare dollars that can be reallocated for many, many other kids, or adults. So I think that's a good example of how these decisions and how having the right leader in place is critical for actual quality healthcare uh, delivery for an individual, but for an entire system. Well, thank you so much, Dr. Scott. It was great having you, and thanks for enlightening folks about what you do, both on an individual level with patients, but on the larger systematic level, because I think it makes a huge difference in the care that we're delivering as a mental health community.
Absolutely. Thanks for having me.
Awesome. Thank you.